If your child's watery, sticky eye persists for a few weeks, you can do simple measures at home to help it and to stop your child looking as though they've got an infection. You can keep the eyelids clean by frequently washing them and wiping them with warm saline water. And if you think there's an infection, you need to see first of all your GP, who will give you some antibiotic drops or ointment. And if it persists and looks as though it's not going to resolve itself spontaneously, then you need to see the paediatric ophthalmologist or an oculoplastic surgeon such as myself, who looks after little children with watery, sticky eyes. There's a lot that you can do for your child's watery, sticky eyes, as well as just cleaning and helping your child not to look as though they've got an infection. First of all, you must be quite emphatic to their nursery that it is not an infection. It is just a delayed opening of the tear duct. They're not going to be infecting other children. However, they could get an infection if there is stagnation of the tears in their tear sac. So we like you to do a little bit of hydrostatic pressure with your little finger over the tear sac, just to empty any stagnant tears and stop your child from getting an infection, a conjunctivitis. Let's say your child is now aged 2 or 3 months and there's been no sign of improvement, then you must come and see the ophthalmic professional. We will assess your child, make sure that all the parts of the tear ducts that we expect to see are there, and we would advise you on the management that you should be doing at home. We don't intervene or do anything surgical until your child is age 1. And the reason for this is we want to reassure you that at least 90% of all children who have watery, sticky eyes are going to get better all by themselves. If your child needs a small procedure of a syringing and probing by the paediatric ophthalmologist or the oculoplastic surgeon, this is done very simply as a day case. And immediately after the surgery, the duct will be free and open. It will have been flushed through, any mucus will have been flushed out, and the watery and stickiness will have gone away. The ophthalmologist will want your child to have some eye drops for a few days or a week after surgery, and then they'll see you back at the clinic with your child a few weeks afterwards. Inevitably, there is going to be a complete cure, except in a very small percentage where there may be a more complex block, in which case we have other small operations for tear ducts for your child which we can offer and do. If your child is over the age of 1 and they still have a watery, sticky eye, in other words, they're not one of the 90% that are going to get better by the age of 1 spontaneously, they may, between the ages of 1 and 4 years, need another procedure. We will assess your child to see what that procedure is. The procedure will likely be an endoscopic endonasal monitoring of a syringing and probing. That's where I put a little torch into your child's nose while they're asleep and make sure there's no cyst at the bottom of the tear duct which is obstructing it from draining, and treat that. Very rarely, extremely rarely, there's a more severe block, possibly a developmental block that hasn't been able to be cleared, and then your child will require a DCR or dacryocysto-rhinostomy operation. After all tear duct surgery on your child, you can expect a very high level of success with elimination of the watery, sticky eye, which has been such a daily bother for you and your family, having to clean your child's eyelids once or twice a day, to tell the local school or the local nursery that your child's not got an infection, or even take them out of the local school or nursery when they had an infection. All that will be behind you. It's really important that you see an ophthalmologist if your child's watering, sticky eye persists and you want to know more about it, and they will be able to advise you on whether treatment is required, and treatment has a very high success rate.